Hello everyone. So in today's lecture we will be discussing about indirect acting cholinergic agonists and those which are of reversible kind. So before discussing them we need to understand what is the role of acetylcholine esterase. So actually if this is the presynaptic neuron and this is the postsynaptic neuron, the acetylcholine esterase is an enzyme which is being attached to both presynaptic or postsynaptic nerve terminals. So it is actually membrane bounded enzyme which is involved in cleavage of acetylcholine, which is being released into the synaptic cleft. Like if synaptic cleft is now filled with acetylcholine because of the action potential coming across this neuron. So what happens when there is presence of acetylcholine in the synaptic cleft? There is also the presence of enzyme which cleave this acetylcholine into acetate and choline. So this enzyme causes the degradation of acetylcholine, and this enzyme is being attached to both presynaptic neuron and postsynaptic neuron. But what happens when we take inhibitors or inactivators of this enzyme? Obviously this enzyme is actually causing the degradation of acetylcholine, but when there is no acetylcholine esterase, there will be no cleavage or no degradation of acetylcholine. So in this way what will happen? There will be increase in the concentration of acetylcholine because now it is not being degraded into acetate or choline. In this way, the inhibitors of acetylcholine esterase are actually indirectly acting as cholinergic agonists, or they are also called as anticholinesterase agents, and they can be of two kinds. One of them is reversible and other of them is irreversible kind. So in this way these drugs are actually provoking a response that cause the cholinergic responses in the whole body. It can cause cholinergic responses at the site of muscarinic and nicotinic receptor of ANS, as well as at neuromuscular junction and in the brain. And these agents, acetylcholine esterase inhibitors, are actually broadly classified as short acting and intermediate acting agents. So we will be discussing about them one by one. So first of all we have an agent which is called as Edrophonium. Now this agent is actually a prototype of short acting. Acetylcholine esterase inhibitor, and it can be reversed. It is not irreversible binding. It binds to acetylcholine esterase and cause the dysfunctioning of this enzyme, but this activity and dysfunction is actually reversible. This drug has duration of action of almost 10 to 20 minutes. Because it is rapidly renally eliminated and therefore it has short duration of action and it is well absorbed into our body. Rapidly absorbed. Rapid renal elimination. Edrophonium is actually a quaternary amine, which means the nitrogen present in its formula is further attached to 4 atoms. So therefore it is called as quaternary amine. Another thing is that it is actually very limited to periphery because it cannot cross blood-brain barrier, so it is actually only acting on peripheral nervous system. It does not go into the brain. so it does not show any CNS effects. And this Edrophonium is also used in the diagnosis of Myasthenia Gravis. And Myasthenia Gravis is actually an autoimmune disease which causes the formation of antibodies which are being attached to the nicotinic receptors at the neuromuscular junction. If this is the muscle and a neuron over here release the acetylcholine, which is then being attached to nicotinic receptor present on the neuromuscular junction. So what happened that these nicotinic receptors are being occupied or being attached to antibodies in this condition. So in this condition there is formation of autoantibodies which cause the attachment of themselves to nicotinic receptor present on the neuromuscular junction. In this way, what happened? There is degradation of the nicotinic receptors and there is presence of only few other receptors which are not being degraded. In this way, there is less of the interaction between acetylcholine and the present nicotinic receptors, because much of the nicotinic receptors are being destroyed by these antibodies. So now as there are fewer of nicotinic receptor, what happened? There is less of the acetylcholine response in the body. So when we give this Edrophonium, what happened? That this Edrophonium caused the inhibition of acetylcholine esterase. In this way, when there is decrease in the acetylcholine esterase, what happened? That there is more of the acetylcholine present over here. So what happened? That this increased concentration of acetylcholine will again and again bind to the nicotinic receptor which are left behind. So it will continue showing its effect. So in this way there will be some of the cholinergic response in the body which was being decreased previously in the case of Myasthenia Gravis. So when we give Edrophonium, it actually increases the acetylcholine activity in the neuromuscular junction. So in this way there is a rapid response or rapid increase in the muscle strength, because in Myasthenia Gravis there is weakness of muscles, but when we give Edrophonium as diagnostic test, what happened? There is a rapid increase in muscle strength. So in this way it is confirmed that this disease the patient having is actually Myasthenia Gravis. But care must be taken because excess of this drug can also provoke a cholinergic crisis. Therefore, we also should have atropine along with us while giving Edrophonium to our patient, because atropine is actually antidote of this Edrophonium. So Edrophonium is also used to differentiate between cholinergic crisis and myasthenic crisis, because both of the conditions have similar symptoms like breathing problems and muscular weakness. But to confirm which of the either is patient having, we need to give him Edrophonium to confirm. So Edrophonium is actually a diagnostic test to confirm which of the either condition the patient having. So if the patient is having cholinergic crisis, Edrophonium will worsen the condition of the patient. So we need to have atropine along with us so that we can reverse the condition of cholinergic crisis. But if the patient is having Myasthenia Gravis, his condition will get better at no time. So in Myasthenia Gravis, we can use Edrophonium for the diagnosis, and we can also use this drug for differentiating between cholinergic crisis and myasthenic crisis. So we can write over here that to differentiate between these two kind of crises which have similar symptoms, we can absolutely differentiate between them by getting the results. And third one is, it is also used for the reversing the effects of non-depolarizing neuromuscular blockers after surgery, because we give such agents to our patient during surgery to provide muscle relaxant properties so that surgery could go on easily. But after surgery we need to reverse this condition, so we give Edrophonium so that it could reverse the condition. So the reversal of the relaxing condition is contracting. So reverse effects of non-depolarizing neuromuscular blockers after surgery. But due to availability of other neuro agents, all of these effects or all of these usage of Edrophoniums are now being limited. So we do not use very often this agent. And our next agent is Physostigmine. This agent is actually nitrogenous carbamic acid ester, which is actually naturally present in many of the plants. So nitrogenous carbamic acid ester. So it is present in plants, and Physostigmine is actually tertiary amine, which means nitrogen present in Physostigmine is further attached with 3 atoms. The mechanism of action of Physostigmine is same as that of Edrophonium, which is it attached at the active side of acetylcholine esterase, and it reversibly inactivate the enzyme and thus cause the cholinergic activity throughout the body. So if we talk about the actions of Physostigmine, it has a wide range of effects, such as it stimulates muscarinic as well as nicotinic receptors of ANS. We write it as muscarinic and nicotinic receptors of ANS. Other than it, it also causes the stimulation of nicotinic receptors at neuromuscular junction. So other than that, it can also cross CNS. So it will definitely show cholinergic effects in CNS, whereas Edrophonium, which we discussed previously, was only involved in peripheral cholinergic effects. Physostigmine is considered as intermediate acting agent because it shows its duration of action for about 30 minutes to 2 hours. So if we talk about the therapeutic uses of this agent, so this agent is involved in increasing the intestinal and bladder motility. So we can use it as therapeutic agent in atony of either of the organs. So atony of bladder or intestine. In these conditions we can use Physostigmine because it increases the motility of intestinal muscles or bladder muscles. We can also use Physostigmine for the treatment of overdose of drugs like atropine, which are actually anticholinergic agents. So anticholinergic agent like very famous atropine In overdoses of such agents, we can use Physostigmine. As Physostigmine can cross CNS and go into the CNS, it can also cause some CNS adverse effects. So it can lead to convulsions when it is given in higher doses. Other than that, it can also cause bradycardia. It can also cause decrease in cardiac output. But remember, all of these are being caused when they are given in higher doses. At therapeutic doses, these adverse effects are rarely seen. So, other than this, as I have told you earlier, that it also affects nicotinic receptor which are present on the neuromuscular junction. So what happens when there is increase of acetylcholine at neuromuscular junction? What happens? The accumulation of acetylcholine can lead to paralysis of skeletal muscles. As we know, when there is increase in or when there is production of acetylcholine, what happens? There is contraction of skeletal muscle. But when there is overproduction or overpresence of acetylcholine, what happens? There is much more of the contraction than that of required. So what will happen? There will be more of contractions of skeletal muscle, which will lead to paralysis of skeletal muscle. What is the kind of paralysis happening over here? It is actually spastic paralysis, in which there is excessive contractions of skeletal muscles. And this all happen only when you are giving high doses of Physostigmine, but at the therapeutic doses, none of these are seen. So Neostigmine is actually a synthetic compound, that it is synthesized or it is man-made product, whereas the previous one, Physostigmine, was naturally present in plants. So Neostigmine is synthetic compound, but it is also carbamic acid ester, and it work on the same principle, that is, it inhibits acetylcholine esterase and it produces some of the cholinergic responses in the body, and it has similar action that of Physostigmine. So if we talk about the actions of Neostigmine in detail, first of all, Neostigmine is a quaternary amine, and quaternary mean that nitrogen present in its structure is further attached with 4 of the atoms. So it is unlike that of Physostigmine, which was tertiary amine. So after that, this quaternary amine makes it more polar, because when there is more of the atoms attached to the nitrogen, what happens? The polarity is established, and this polarity makes it poorly soluble from the GI tract, and in this way it does not enter CNS. So poorly absorbed and does not cross CNS. In this way, it has only peripheral effects. It does not go into the CNS and does not show any of the CNS effects. It has much greater effects on skeletal muscle than that of Physostigmine. So it stimulates contractility, which is actually shortening or shrinkage of muscle cells before it actually cause paralysis. So it stimulates shrinkage of the cells before it cause paralysis of the skeletal muscles. It is also one of the intermediate acting agent because it has duration of action 30 minutes to 2 hours. So if we talk about the therapeutic uses of this agent is involved in stimulation of bladder and GI tract muscles. Not only this, it is also involved in management of Myasthenia Gravis. As we have discussed earlier that Myasthenia Gravis is an autoimmune disorder in which some antibodies are formed inside the body which actually go to the nicotinic receptors present in the neuromuscular junction and thus destroy these receptors, which in turn cause the decrease in the activity of cholinergic responses. So what happens that when we give these agents like Neostigmine, what happened that it caused the increase of the acetylcholine present at that position, and in this way what happened, there is increase of the response of nicotinic receptors because more of the agonists will bind to the receptor and they will show their cellular responses. So in this way it is actually used for the management of Myasthenia Gravis. Other than that, Neostigmine is also used as an antidote of competitive neuromuscular blockers. Now, neuromuscular blockers are often given before surgery to cause relaxation of muscles of the patient, but in case of high dosage or overdose, what happens, we need to inject antidote for that neuromuscular blocker. So what we do is that we give our patient Neostigmine as an antidote for such competitive type of neuromuscular blockers. These are some uses of Neostigmines. But other than that, if we talk about adverse effects, as Neostigmine is indirect acting cholinergic agonist, so what happened that it is increasing cholinergic responses in our body. So if there is increase of such responses, what will happen, there will be cholinergic crisis. Generalized effects of cholinergic stimulation, they are like salivation, flushing, decreased blood pressure, nausea, abdominal pain, diarrhea, bronchospasm. As this agent do not cross CNS, so there is no CNS effects, and therefore this agent is also not used to overcome toxicity of central acting such as atropine, because atropine can go into the CNS and can cause antimuscarinic effect over there, but this agent Neostigmine cannot cross CNS, therefore it cannot be used to overcome toxicity of agents like atropine, which is centrally acting agent. And if we talk about contraindications, so this agent is actually contraindicated in the case of intestinal or urinary bladder obstruction. So next agents are Pyridostigmine and Ambenonium. So these agents are also acetylcholine esterase inhibitor. So they are also used in the chronic management of Myasthenia Gravis. And their duration of action is also intermediate. Pyridostigmine has duration of action of about 3 hours to 6 hours, whereas Ambenonium has its duration of action ranging from 4 hours to 8 hours. But both of these duration of actions are longer than that of previous agent that we have discussed. But these agents still fall in intermediate acting agents. And if we talk about the adverse effects of these agents, they are similar to that of Neostigmine. So let's move on to the next agents, which are Tacrine, Donepezil, Rivastigmine and Galantamine. So what happens in Alzheimer's disease is that there is decrease in the cholinergic neurons. When there is decrease in the cholinergic neurons, what we can do is that we can give anticholine esterase, and what they do is that they increase the effect of cholinergic responses in our body. So first agent, that is Tacrine, it was first available agent, but because of its excessive hepatotoxicity, it is being replaced by others. So all of these agents are being used in the delay of the progression of Alzheimer's disease, but none of them can actually stop the progression because it is not a treatable disease yet. So what we can do is that we can delay the progression of this disease by these agents. So these agents actually have a primary adverse effect, which is GI distress. So this was all about indirect acting cholinergic agonists, which are of a reversible kind. These are also called as anticholinesterase agents. So these agents were of reversible kind, that they do not bind covalently to the acetylcholine esterase, but they can be reversed by giving any competitive agonist. Other type of these agents are irreversible anticholinesterase agents, and we have discussed them already in our previous video. If you haven't watched it, you can go to my channel and you can watch it over there. So this was all about indirect acting cholinergic agonists. If you have any question, let me know in the comment section below, and thank you for watching my videos.